So let's take a look at the antacids and management of GERD. GERD, or gastric esophageal reflux disease, is one of the most common chronic conditions for which patients in the United States take daily medications. Heartburn and regurgitation associated with GERD were found to produce symptoms at least once per week in 20% of the population and occur at least twice per week in 6% and 3% of the adult population, respectively. GERD involves the movement of stomach contents back into the esophagus. Most patients have very mild disease, although it's possible for the patient to develop rare complications such as active erosive esophagitis, esophageal adenocarcinoma, and esophageal stricture. The main symptoms of GERD is heartburn that occurs 30 to 60 minutes after meals and when the patient bends over or lies down. Relief is usually reported after antacids are taken. Other symptoms include nonspecific GI symptoms, such as regurgitation of sour or bitter gastric contents, belching, and fullness of the stomach. Typical symptoms include chronic cough, chronic laryngitis, asthma, sore throat, and non-cardiac chest pain. Erosive esophagitis may have more severe symptoms such as pain and dysphagia, but also may be relatively asymptomatic. Esophagitis is divided into 4 grades, which are determined endoscopically. Grade 1 is defined as erythema of the distal esophagus. Grade 2 consists of scattered erosions. Grade 3 involves confluence of erosions involving less than 50% of the diameter of the esophagus, and grade 4 involves erosions involving greater than 50% of the diameter. As providers, we must ask specifically about antacids and other over-the-counter remedies when taking a medication history. Many patients will have tried over-the-counter remedies before going to see their primary care provider. Most will have tried antacids, over-the-counter histamine blockers, or proton pump inhibitors. Many patients do not consider antacids to be a medication and will not mention taking them when asked about medication use. Upper endoscopy with biopsy is the standard diagnostic procedure for GERD. It confirms the diagnosis and documents the type and extent of tissue damage. Uncomplicated GERD that is responsive to first-line therapy does not require an endoscopy. For most patients, empiric treatment is initiated based on history and physical exam. Acid suppression therapy with antacids, histamine 2 receptor antagonists, or proton pump inhibitors are extremely effective in controlling GERD symptoms, but they can also be problematic because of the high associated costs of many of these medications and the need for indefinite therapy duration in most patients. Patients who do not respond to therapy and those who with suspected complications should undergo an endoscopic exam. The differential diagnosis includes peptic ulcer, cholelithiasis, non-ulcer dyspepsia, and angina pectoris. Many patients need to be evaluated for H. pylori infection as well. The class of medications, antacids are rarely prescribed as first-line treatment. Usually the patient has been using over-the-counter antacids before coming to the healthcare provider. These medications are commonly for gastroenterologic diseases such as reflux, esophagitis, and peptic ulcer. The antacids most commonly prescribed have at least one of the following elements in their main ingredient: calcium carbonate, aluminum salts, and magnesium. The ingredients may provide barrier protection and is useful in the management of GERD. The key antacid is considered to be calcium carbonate because of its widespread popularity, cost effectiveness, and ease of use. We all know this as Tums or Rolaids. However, combination antacids, in particular combinations of aluminum hydroxide and magnesium hydroxide, are probably the most commonly used antacids. Amphigel and Basagel. Antacids vary in their sodium content, in magnesium content, which can be a problem in kidney failure, and in the tendency to cause diarrhea or constipation. So a lot of these medications we're familiar with. A lot of them we've seen not only in practice but out over the counter. The calcium salts, tons of rolaids, sodium bicarb alka-seltzers, aluminum salts, the amphogel and basogel, the magnesium salts, milk of magnesia or magnesium oxide, and the combination products such as Maalox and Mylanta, which include albumin hydroxide and magnesium hydroxide, and Gaviscon, which is alginic acid, magnesium triacylate, and calcium stearate. So the indications for hyperacidity, heartburn, GI reflux, and acid indigestion. For hyperacidity associated with a peptic ulcer, gastric hyperacidity, and sour stomach. Calcium carbonate is specifically used for gastric hyperacidity, hypocalcemia, hypoparathyroidism, hyperphosphatemia, hypertension, heartburn associated with pregnancy. Aluminum hydroxide is useful in gastric hyperacidity, gastritis, and peptic ulcer. The magnesium hydroxide, occasional treatment of constipation, magnesium deficiencies, magnesium depletion from malnutrition, restricted diet, alcoholism, and magnesium depleting drugs. Unlabeled uses, Gerd, not first-line therapy. Antacids with aluminum and magnesium or aluminum hydroxide prevent stress ulcer bleeding, duodenal ulcer, and maybe gastric ulcers. Calcium carbonate can be used for the prevention and management of osteoporosis. So what are the mechanisms of action? Antacids are weak bases that neutralize gastric hydrochloric acid by combining with it to form a salt and water. This process decreases the amount of gastric acid in the stomach, raises the pH. Antacids decrease pepsin activity because the pepsin is rendered inactive in alkaline conditions. Antacids also have a number of cytoprotective effects. They may enhance mucosal prostaglandin levels. Aluminum ions inhibit smooth muscle contraction, thereby slowing gastric emptying. This is counterproductive because in GERD, prompt gastric emptying is beneficial. Aluminum binds epidermal growth factor, thus delivering growth factor to the injured mucosa. Antacids do not protect the stomach by coating the mucosal lining. Alginic acid is not an antacid because of the presence of saliva. It reacts with sodium bicarbonate to form a sodium alginate, and it protects the mucosa from its forming viscous and floating properties. This foam may provide a barrier to reflux or stomach contents into the esophagus. The ability of antacids to neutralize gastric acid has been labeled acid neutralizing capacity. The ANC is the quantity of 1 HCl expressed in milliequivalents that can be brought to pH 3.5 in 15 minutes, expressed in milliequivalents per milliliters. Antacids with high ANC usually are more effective than others. So again, you'll be looking for, if a patient has a very severe case, you want to look for antacid that is high in ANC to be more effective. So for the alginic acid, it's not considered an antacid in the presence of saliva. It reacts with sodium bicarb to form a sodium alginate. Protection of the mucosa is created by a foaming, viscous, and floating properties, and may provide a barrier to reflux of stomach contents into the esophagus. So what are the treatment principles? Evidence-based recommendations. The H2 inhibitors reduce the risk of persistent esophagitis, but are not as effective as the PPIs, or protein pump inhibitors, in terms of their ability to neutralize acid. Antacids reduce symptoms, but do not have a significant effect on healing of erosions or esophagitis. The cardinal points of treatment. Patients should begin by making lifestyle changes in diet and managing stress. This is a lifelong disease. For patients with esophageal GERD symptoms, treatment with anti-secretory drugs is recommended for healing of the esophagitis, symptomatic relief, and maintenance of esophageal healing. In this situation, protein pump inhibitors are more effective than the histamine 2 receptor antagonists, which in turn are more effective than placebos. Once PPIs have proven clinically effective for the treatment of patients with esophagitis, therapy should be continued long-term and titrated down to the lowest effective dose on a basis of symptom control. When treatment with anti-reflux surgery or PPIs is thought to be similarly effective in the patient with esophageal GERD syndromes, PPI therapy is considered safer and therefore preferred initial treatment. Anti-reflux surgery should be recommended when a patient with esophageal GERD syndrome cannot tolerate acid suppressive therapy, even if pharmacotherapy is effective. In patients with suspected reflux chest pain syndrome, an empiric trial of twice-a-day PPI therapy is recommended after careful evaluation for a cardiac cause. You need to rule out the cardiac cause first and then treat for reflux. Patients should begin by making lifestyle changes in diet as well as managing stress. For diagnostic guidelines, first, number one, empirical therapy. If a patient's history is typical for uncomplicated GERD, an initial trial of empirical therapy is appropriate with lifestyle modifications, particularly weight loss and diet control in the obese patient. Lack of response does not rule out GERD. Additional testing should be considered if GERD symptoms are refractory to empirical therapy. Treatment guideline number 2, patient-directed therapy. Antacids or H2 receptor antagonists and prazole are available over the counter. Patients should not self-medicate for longer than 14 days without further evaluation. Treatment guideline number 3, acid suppression. The mainstay of treatment for GERD is acid suppression. PPIs are the first-line treatment because they are the most effective option. Few data favor one agent over the other. Long-term therapy is beneficial in a chronic and complicated GERD. Higher than approved dosages may be indicated for certain situations. To achieve optimal benefit, PPI should be taken 30 to 60 minutes prior to the timing of other medications, breakfast, or evening meal. H2 receptor agonists may be used as a pre-medication before meals. Efficacy may outlast that of antacids. Once-a-day dosing is not appropriate as long-term therapy for GERD. Promotility agents, cisapride and metoclopramide, have poor side effect profiles but may be used as adjunctive acid suppression therapy for GERD. Promotility agents may eliminate the root cause of GERD and may make acid suppression unnecessary. Motility agents are not effective as monotherapy for GERD. The goals of treatment include symptomatic relief and prevention of complications. GERD is a lifelong disease that requires lifestyle modifications and medications as indicated. For non-pharmacological treatment, again, lifestyle modifications from form the foundation of treatment. Newer guidelines suggest that lifestyle modification should be combined with the use of an antacid or other medication. Many patients can relieve their symptoms by incorporating lifestyle changes without taking medications. Lifestyle modifications include diet, weight loss if overweight, increased activity, elevation of the head of the bed, cessation of smoking and alcohol use, and avoidance of drugs that decrease LES pressure. Gerd refers to endoscopically determined esophagitis or endoscopy negative reflux disease. Patients with uninvestigated reflux-like symptoms should be treated similarly to patients with uninvestigated dyspepsia. Medical treatment is based on the severity of symptoms. For the PPI, offer patients with Gerd a full dose of PPI for 1 to 2 months. If the symptoms reoccur following initial treatment, offer a PPI at the lowest dose possible to control symptoms, along with a limited number of repeat prescriptions. Discuss with the patient using the treatment on an on-demand basis to manage their own symptoms. You can offer H2 RA or prokinetic therapy if response to the PPI is inadequate. For mild intermittent symptoms, antacids are used for immediate relief of intermittent heartburn. Because their duration of action is only 2 hours, H2 blockers or PPIs can be used if symptoms last longer than 2 hours, or if they occur at night. Over-the-counter doses are usually sufficient. These drugs require at least 30 minutes to take effect. They also can be taken before meals, before a meal that is expected to cause heartburn. For moderate symptoms, patients who experience symptoms several times a week or daily should be treated with a PPI or prescription strength H2 blocker. Twice-a-day dosing of the H2 blocker or once-a-day PPI will provide 24-hour reduction in acidity. PPIs often are used as first-line treatment because they are more effective in reducing acid when compared to the H2 blockers. They provide the advantage of once-a-day dosing, but they are much more expensive. One PPI and Perazole is available over the counter for 14 days of use in both generic and brand forms. Patients should not self-medicate with Perazole for longer than 14 days without undergoing further evaluation because of the risks of Barrett's esophagus and other complications. Treatment for moderate symptoms should continue for 4 to 8 weeks. Intermittent treatment for treatment when symptoms reoccur is usual. Plan a treatment for mild to moderate diseases. For those patients with severe symptoms or erosive disease, if the patient has severe symptoms, has found treatment for milder symptoms to be ineffective, or has experienced erosion that is documented by endoscopy, he or she should be started on a PPI. Initial dosing is provided at the usual starting dose of once a day. If this is not effective, the dose should be increased to twice a day. The usual course of therapy is usually 8 to 12 weeks, which allows for healing of the erosions. Repeat endoscopy is not required if the patient responds to treatment. Most patients should be allowed a trial off medication, although relapse is frequent at a rate of about 80%. If cases of relapse, usually within 1 to 3 months, occur, maintenance therapy should be provided. The dose used for maintenance therapy may not have to be as high as the initial treatment. If the patients do not respond to that therapy, they should be referred for consideration of anti-reflux surgery, which may provide a cure. Pro-motility drugs such as metoclopramide or bethanyl reduces reflux by increasing the LES tone and promoting peristalsis and gastric emptying. Because of the potential for serious adverse effects, these agents are not recommended for Gerd unless therapy with a PPI or an H2RA yields no response. Sulfate enhances mucosal protection. These drugs are frequently added into a standard regimen. Additional considerations, antacids with the highest ANC include sodium bicarbonate and calcium carbonate. Sodium bicarbonate is not suitable for long-term use because of side effects. Calcium carbonate requires monitoring for long-term effects. The clinician must consider drug formulation because it affects efficacy. Suspension and gel formulations have higher ANC than do powders or tablets. Tablets must be chewed thoroughly to be effective. They work best if taken with a full glass of water. Tablets may be more convenient for occasional indigestion. Again, timing of the antacid administration is important for the greatest effectiveness. They should be taken 30 minutes after meals. This increases the amount of time that the antacids is in the stomach and is functioning as an antacid. Taking antacids on an empty stomach is not as effective because of the short transit time through the stomach. Taken properly, their duration of action is 2 hours. To avoid drug interactions, it's important to take antacids 1 hour before or 2 hours after taking other medications. For antacids with calcium, these may cause constipation. Aluminum may cause constipation, and magnesium can cause diarrhea. The second two ingredients usually are given together to balance the effect of the bowels. Antacids with sodium bicarbonate have significant sodium to cause problems with patients with hypertension or congestive heart failure. Other antacids vary in their sodium content by brand name. If the patient is on a low salt diet, the sodium content of the antacid should be checked before prescribing. If the patient has any renal insufficiency, magnesium intake should be limited. If given magnesium levels should be checked periodically. Antacids with calcium may precipitate kidney stones in the predisposed patient. Antacids were the mainstay of treatment for Gerd and Peptic ulcer disease for many years until the anti-secretory agents were developed. Antacids are less convenient, less palatable, and less effective than the anti-secretories in reducing acid, and they have a higher incidence of unpleasant side effects, especially diarrhea and constipation. How to monitor these patients. Monitor the electrolytes, magnesium, sodium, and calcium levels as indicated with long-term use of antacids. Evaluate therapeutic effect by following symptom resolution. Assess GI and renal status, and monitor for adverse effects. For patient variables, for geriatric patients, avoid using antacids that contain magnesium in elderly patients with renal failure because they may develop hypermagnesium. Avoid sodium-containing antacids because of fluid retention. For pediatrics, safety has not been established in children. Drugs commonly used for Gerd in children are famotidine, nizamidine, ranitidine, esomeprazole, lansoprazole, omeprazole, and pantoprazole. For pregnancy, no FDA category has been established, although antacids generally are considered safe for use in pregnancy. However, you should avoid antacids containing sodium bicarbonate in the pregnant woman. For patient education, the patient should notify the healthcare provider of taking any other medications. Antacids may interact, so they should be taken 1 hour before and 2 hours after the medication has been taken. If chewable antacid is prescribed, chew the tablet completely and follow by drinking at least 8 ounces a glass of water. Shake liquid preparations thoroughly before taking to ensure accurate dosing. Remember, if a liquid, the medication may settle at the bottom and they will have minimal amount of medication at the when they first pour the medication, and when they get down to the bottom, this could have higher dosaging and cause toxicity. Store liquid formulations at a cool place, but do not freeze. Refrigeration may make them taste better. Antacids may cause constipation, especially aluminum. or diarrhea, the magnesium. Either should be reported to the healthcare provider. Often aluminum and magnesium are combined to balance out the individual effects on the bowel. The patient should notify their provider if they see symptoms of bleeding, such as black tarry stools or coffee ground vomitus. The effectiveness of the antacids decrease with age of the medication, so make sure that the patient knows to discard out-of-date antacids. Antacids should not be used for longer than 2 weeks without further evaluation by a provider. And patients often have questions about why dual ingredients are included. Some falsely believe that magnesium increases absorption of calcium. This is more for the diarrhea. Now we'll move on to the histamine 2 blockers and protein, specifically protein pump inhibitors and histamine 2 blockers. These are anti-secretory agents, the H2 receptor antagonists, H2 blockers, such as ranitidine, samantidine, famotidine, and azamidine, or the protein pump inhibitors, omeprazole, esomeprazole, lansoprazole, pantoprazole, and rabiprazole. These are indicated, the H2 blockers and H2 receptor antagonists for duodenal ulcer treatment and maintenance, gastric ulcer treatment, Gerd, gastroesophageal reflux disease, pathologic, hypersecretory conditions, and for the protein pump inhibitors, these are used for gastric and duodenal ulcers, as well as Gerd and pathologic hypersecretory conditions, and H. pylori. The H2 blockers, H2 receptor antagonists, and PPIs block acid secretion in the stomach, but do so via different mechanisms of action. In general, all H2 blockers except samantidine are considered equally effective and have similar side effect profiles. PPIs generally are considered to be more powerful in terms of action than H2 blockers because they decrease stomach acidity to a greater extent. 6 PPIs are available, and little difference between them has been noted except for duration of action. This may be increasing as we talk because this is an active area of research. Medications that inhibit secretion can act in several ways at several locations on or in the oxygenatic cell. H2 receptor antagonist drugs can bind to the H2 receptor, thereby displacing histamine from receptor binding sites and preventing stimulation of the oxygenatic cell by the secretagogue. The 4 H2 receptor antagonists have similar chemical structures. They reversely inhibit basal or histamine, panagastrin, or meal-stimulated acid secretion in a linear, dose-dependent manner by interfering with histamine at the H2 receptors on the gastric parietal cells. As much as 90% inhibition of the vagal and gastrin-stimulated acid secretion occurs with these agents, reflecting the importance of histamine in the mediation of cholinergic and gastrin-stimulated acid secretion. Near complete inhibition of nocturnal acid secretion may be achieved as well. For the PPIs, PPIs irreversibly inhibit the acid secretory pump embedded within the parietal cell membrane by altering the activity of hydrogen potassium ATPase. This enzyme affects the secretory pump in the gastric parietal cell by inhibiting hydrogen ion transport into the gastric lumen and by decreasing stimulation of acid secretion. It decreases the volume of gastric fluid. An increase in serum gastrin concentrations have been observed, however. Because the PPIs act on the basolateral membrane of the parietal cells, they do not affect gastric emptying. Basal or stimulated pepsin output or secretion of intrinsic factor. This type of drug does not seem to affect the AT pace in other organ systems. For ulcer treatment principles, peptic ulcer is defined as a break in the gastric or duodenal mucosa that extends through the muscularis mucosae. It arises when the normal mucosal defensive factors are impaired or overwhelmed. Duodenal ulcers are more common between the ages of 30 and 55 years. In males, gastric ulcers are more common between the ages of 55 and 70 years. Ulcers are 5 times more common in the duodenum than in the stomach. Duodenal ulcers are almost never malignant, whereas 3 to 5% of the gastric ulcers are. 3 important causes of peptic ulcer disease have been identified: nonsteroidal anti-inflammatory use, H. pylori, and acid hypersecretory states such as Zollner-Ellison syndrome. The provider should confirm the presence of H. pylori and any NSAID use before determining what therapy is warranted. For evidence-based recommendations, to facilitate healing and to decrease the risk of recurrence of gastric and duodenal ulcers, H. pylori should be eradicated in patients with peptic ulcer disease. PPIs offer suppression of acid secretion, healing, and symptom relief in patients with peptic ulcers that are superior to those associated with other anti-secretory therapies. Patients with bleeding peptic ulcers should be treated with a PPI to decrease the need for transfusion or surgery and to reduce the duration of hospital stay. Those with bleeding peptic ulcers and positive H. pylori testing should have eradication therapy prescribed. Patients with perforated ulcers should undergo eradication of coexisting H. pylori infection. Successful eradication should reduce the need for long-term anti-secretory therapy and additional surgery. For the cardinal points of treatment in patients with ulcer symptoms, treat H. pylori if present. This is essential to resolving the problem and not just treating the symptoms. Patients should stop NSAIDs use if possible and begin PPI therapy along with lifestyle modifications, particularly dietary changes with stress management. For non-pharmacological treatment, lifestyle modifications are integral to treatment for peptic ulcer disease. Recommendations no longer include bland or restrictive diets. Patients should eat balanced meals at regular times and should avoid foods that exacerbate their symptoms. High fiber is encouraged. Caffeine causes increased acid secretion and should be avoided. Alcohol can aggravate an ulcer, but usually does not appear to be harmful when taken in moderation. Smoking should strongly be discouraged. In general, PPIs are used first line because they are more potent and require a shorter course of treatment. H2 blockers are less expensive and are usually effective. If the patient does not start to see improvement within a few days, increase the dosage of medication or change from an H2 blocker to a PPI. Goals include relief of symptoms and healing of the ulcer. Treatment consists of a course of H2 blocker or a PPI. In general, PPIs are used first line because they are more potent and require a shorter course of treatment. H2 blockers are less expensive and usually are also effective. If the patient does not start to see improvement within a few days, increase the dose of medication or change from an H2 blocker to a PPI. H2 blockers such as ranitidine, famotidine, samantidine are associated with 70 to 80% healing of duodenal ulcers after 4 weeks, with 87 to 94% healing after 8 weeks. PPIs should be given for 4 weeks for a duodenal ulcer and 8 weeks for a gastric ulcer, and are associated with 80 to 100% healing. The H. pylori organism must be eradicated to prevent recurrence. Several treatment regimens are available. In general, an acid suppressant such as an H2 blocker or a PPI is combined with an antibiotic. 14 days of treatment may be more effective than 7 days of treatment. Occasionally, this regimen includes bismuth. H. pylori has occasionally developed a resistance to claramycin. After this treatment has been completed, continued treatment of the ulcer with an acid suppressant is often necessary. For the NSAID-induced ulcer, the patient should discontinue the NSAID if possible and use a standard dosing regimen of an acid suppressant. Sometimes it is impossible to discontinue the NSAID. Prevention of ulcers is used for high-risk patients on NSAIDs, such as those with a history of ulcer disease, concurrent therapy with corticosteroids, or anticoagulants, severe illness, or advanced age. Options include PPIs or H2 blockers, misoprostol, or a COX-2 selective nonsteroidal anti-inflammatory. For the refractory ulcers, these are non-healing after 8 to 12 weeks, are uncommon with anti-secretory drugs and or antimicrobial therapy. Consider pathologic hypersecretory conditions and refer the patient to a gastroenterologist. Patients with non-healing gastric ulcers should be evaluated for cancer through repeat endoscopy after 3 to 4 months. Symptomatic response does not preclude the presence of gastric malignancy. For the H2 blockers, all H2 blockers are capable of healing duodenal ulcers, relieving the symptoms, and preventing complications. They are all well tolerated and have a remarkably low incidence of side effects, usually less than 3%. Single dosing at bedtime of an H2 receptor antagonist blocker has been approved for the treatment of acute peptic ulcers. Even evening dosing appears to provide optimal 24-hour inhibition. Early evening is the optimal time for once daily dosing. Because all H2 blockers have basically the same efficacy, there is no reason to switch from one to another if no symptomatic response is noted. Samantidine is available over the counter but has numerous drug-to-drug interactions. All other H2 blockers are also available over the counter but do not exhibit these interactions. For the protein pump inhibitors, the PPIs are the most potent available inhibitors of gastric acid secretion and require a short duration of treatment. Another advantage is their once daily dosing, which improves patient compliance. Because the PPIs affect the actively secreting parietal cells, they should be given at mealtime. H2 receptor antagonists should not be used concurrently with PPIs. Only omeprazole and lansoprazole are available over the counter. How to monitor these patients? The patient should be checked stools and emesis for blood. It takes 72 hours to clear the stool from the GI tract from a former bleed. Once a stool is negative for blood, no further hemocoagulation tests are necessary unless symptoms return or worsen. Assess for confusion, especially in elderly or debilitated patients and those with renal or hepatic dysfunction. Unusual weakness or tiredness may suggest blood dyscarrias or anemia due to chronic B12 malabsorption. For the H2 blockers, monitor liver enzymes and platelets. Consider monitoring renal function, especially in the elderly. Patient variables for geriatrics: decreased liver and renal function may decrease elimination of these drugs, reduce the dose by 1/2. No adjustment of dosage is necessary with the PPIs. For pediatric patients, H2 blockers and PPIs are indicated for certain conditions, and dosages depend on the indications as well as the age or weight of the child. You need to look these up, use the appropriate reference tool for dosage for the particular indication. Clinical experience in children is limited. Safety and efficacy has not been established. Samantidine is not recommended for children younger than 16 years of age. In those patients that are pregnant and lactating, all H2 receptor antagonists cross the placenta. Although they are believed to be safe, these agents are not recommended for use in the first trimester of pregnancy or by nursing mothers. The H2 blockers, lansoprazole, esomeprazole, rabeprazole, pantoprazole, and delansoprazole are all Category B. Category C is umeprazole. H2 blockers and PPIs are secreted in the milk. There are some higher levels of umeprazole with equivalent doses have been noted in Japanese and Asian subjects, so consider lowering the dose for these patients. For the H2 blockers, do not take within 2 hours of antacid ingestion. H2 receptor antagonists should be given after meals and at bedtime. If using once-a-day dosing, give medications before bedtime. The patient should report any blood in the vomit or stool or any dark tarry stools or any unusual weakness or tiredness. This may suggest some blood dyscharias or confusion, especially in the elderly. Oral suspension should be shaken vigorously for 5 to 10 seconds before use, and any unused oral suspension should be discarded after 30 days. For those protein pump inhibitors, the capsule should be swallowed whole. Instruct the patient not to crush or chew the capsules. PPI should be taken before meals. Course of therapy are intended for short-term therapy. Despite this, many patients continue taking long-term under the assumption that they should do so. The PPIs and H2 blockers should not be used concurrently unless prescribed by a gastroenterologist and the patient is closely monitored.